Okay. Yeah, when considering the best way to present this month's webinar, I felt a little removed from the crisis response services that are provided in Lyons Township and how those services are developing and changing. And as you know, our community mental health boards fund providers who deliver services to the community. Therefore, I felt the best and most current information would come from those in the trenches, our providers and of those services. So I wish to introduce Greg Lee and Sydney Talavera from Pillars Community Health. Since November 2020, Greg Lee has been the Senior Vice President of Behavioral Health at Pillars Community Health. In this role, Greg is responsible for the organization's community mental health center programs, including outpatient mental health, substance use treatment, crisis services, and community-based programs. He is currently a member of the Board of Directors of Illinois Health Practice Alliance and the Board of Managers for Provider Co. He came from Meridian Health Plan, where he spent 4 years as the Director of Behavioral Health for Medicaid plans. In addition, Greg represented Medicaid Managed Care as a participant on the Governor Pritzker's Mental Health Parity Work Group. Previously, he joined Simpatico in 2013. He was working nationally as part of the business development management team, supporting the design and implementation of new managed care health plans with Centene. Prior to that, he was part of the business development and clinical implementation activities for Centene. He previously worked at DuPage County Health Department and started in community mental health as director with Heartland Human Care Services in 2008. He's a licensed clinical social worker, receiving both his bachelor's and master's at Loyola University Chicago. Sydney Talavera, LCPC, is an experienced clinical counselor who has dedicated her career to assisting individuals experiencing a mental health crisis. She's her primary focus is as the Director of Crisis Services for Pillars Community Health, and it is to use her direct service experience to supervise and manage the mobile crisis response team. As an elected member of the CESSA Advisory Committee, her goal is to improve the system for individuals experiencing a mental health crisis in the state of Illinois through the identification of service providers and policies to support individuals. She has another goal: to build access to the services needed to improve a person's life functioning. Okay, I'm going to hand it over to Greg Lee right now. Greg?
Thank you very much, Ron. I appreciate it. Again, I apologize for the technical difficulties to start. Hopefully we'll be fine and it'll be smooth sailing going through. I appreciate the introduction. I have some familiarity with this particular group through some of the different mental health boards throughout the state, both in my time with Pillars Community Health and with Meridian Health Plan as well. So I appreciate the opportunity for us, both Sydney and myself, to be able to talk to you a little bit about the crisis system. I think, well, what I'll do is I'll share some slides and we'll go through. I'll spend a little bit of time here. I'm not the best at talking and sharing my screen at the same time, so give me 1 second. Okay. Okay, can everybody see my screen? Or wait, you can see my note screen, correct?
We can see your screen, yep.
How's that? Is that better?
Yep, we can see the outline and the next slide. I think
I switched it. You want the first one? I actually had it right this time. I apologize.
Very good.
Great. Okay. So I was appreciative when Ron reached out and asked us to do a presentation. I know there's representatives from the entire state here. And so, one thing I want to stress is this is Pillars Community Health experience as a provider in Western Cook County, suburban West Cook. Things are happening at different paces and in different ways all across the state. So certainly, hopefully, we will provide kind of a baseline of maybe where the state's at, what some of the expectations are in our experience, but also would encourage you to talk to your local providers as well, because like I said, different things are happening across the state. So what I wanted to do is just start and give a little bit of an overview of who Pillars Community Health is, so you can get a baseline of that as we talk about our involvement in the crisis system. I will talk a little bit about kind of the overview of where the state's at from the crisis system, talk about 590 funding and what those requirements are related to mobile crisis response, and then the implementation of 988 and the CESSA, the Community Emergency Services and Support Act, that is in the process of being developed and implemented right now. So real quick, Pillars Community Health, we're a product of, if you're familiar with what's traditionally was known as Pillars, which was primarily a community mental health center. We merged with Community Nurse Health Center, which was located in LaGrange about 5 years ago now, to be one of the first nonprofits in Illinois, and really in a kind of a unique situation, being able to offer both primary care, medical and dental care through our federally qualified health center, as well as behavioral health services through our community mental health center, as well as a whole host of other supports and social services. We're primarily located, our administrative offices actually just moved to Countryside, Illinois, but we basically cover from the city to the DuPage County line in the western suburbs. So all the way from Hickory Hills up north to about Oak Park River Forest area, with programs that obviously have different communities as well. But you can see our office locations listed there on the screen. We're actually just proud to say we're actually 102 years old now. We turned 100 during the pandemic, and we're able to celebrate after the pandemic with a major celebration. But Pillars Community Health has been around for over 100 years at this point, and has been a variety of different organizations during that time, and really have our roots in kind of the founding of social work in Chicago. So it's exciting to see where we're at today and all the different services that we provide. So as I said, we're a federally qualified health center, primary care, dental. We offer psychiatry and a certain level of behavioral health services, primarily focused on brief intervention as part of our health center services. We also offer sexual assault and domestic violence services, which include emergency shelters, medical and legal advocacy, as well as some behavioral health counseling services directly through that programming. And then, as I mentioned, we're a community mental health center. So we offer kind of most of the standard CMHC services, which include outpatient mental health, our crisis services, as well as community support team, a lot of those services that are specific to the Medicaid system, and have some services that fall outside of community mental health, such as our substance use treatment programming through SUPER, an IPS employment program that's funded by the state, and then several different types of school-based initiatives to offer behavioral health supports and services to a variety of different schools throughout the communities that we serve. You may have heard of Buddy's Place. We're a childhood grief and bereavement program that has pretty far reach, at least in the Chicagoland area. And then just 2 weeks ago now, opened a new program called The Loft at 8 Corners, which is focused on teen mental wellness and being able to engage teens high school age in education, prevention, and early access to mental health services, rather than hopefully getting ahead of before it becomes so intense or acute that they need more intensive treatment. So that's kind of who we are as an organization. That's a pretty high level overview, but hopefully that gives you some outline of where we're at. We have been a crisis provider for well over 2 decades. Our primary crisis services have traditionally been rooted in the old SAS program, which is now referred to as mobile crisis response. So we've been providing mobile crisis response services for, I think it's going on 20 years at least right now, but I've always offered some level of crisis intervention. So as I mentioned, I want to talk about 988 implementation, the 590 program, which is specific to mobile crisis response in the Department of Mental Health, and then the CESSA legislation. One of the things that we've been trying to understand better with the state of Illinois and the Department of Mental Health specifically, because they fund us as a 590 provider, is just what the overall vision of the crisis system is. There's a lot of moving pieces right now, a lot of different initiatives, and really trying to put together the whole picture. So these are kind of in order of what's taking place. The vision from the state and DMH is that they further develop the crisis lines and the call centers to be able to meet the need to support 911 and other creating more access points for people to seek the help and support they need in the moment, and to be able to triage the follow-up services much more quickly. Part of that would be access to mobile crisis teams. That's the 590 funding that you typically hear about, where it expands mobile crisis as a service beyond the kind of the youth Medicaid system, and really being able to offer that as part of a crisis continuum across the entire state. So that's having somebody respond. And then these crisis receiving and stabilization facilities that offer services and supports to every type of individual. So right now, as you probably are well aware of, the access point for many people is the emergency room or the hospital first. And that's how the system is obviously looking to be able to provide intervention much earlier in the community before people get to the hospital, before they get to an emergency room. What we don't have in the state of Illinois is really that number 3, those crisis receiving and stabilization facilities. There's a variety of living room programs funded by the statewide. There's a few different providers across the state that have crisis residential or crisis respite, but it's certainly not widespread enough that there's a place to be able to go. If you can avoid the hospital, but more immediate or intensive services might be needed in the moment, there's not too many options at this point in time. All of their vision is really rooted in the CESSA model, and for mobile crisis response, that is really incorporating individuals with lived expertise into the mobile crisis response system. The idea is to be able to better connect 911 and 988 and other hotlines so that law enforcement can respond, for lack of a better phrase, more efficiently in terms of how they deploy their resources. So whether it be a coordinated response with law enforcement and a mobile crisis response team, law enforcement only, or mobile crisis response team only, those are some of the things that are hopefully going to be decided in the very near future and are being worked on right now. The numbers 3 and 4, I apologize about the numbering there, but implement real-time GPS technology in partnership with the region's crisis call center. That's something there's subcommittees working on this, how to use technology a little bit better with the technology that's out there from a GPS standpoint to get people to get quicker responses and get people connected to services more quickly. Cindy will talk about a little bit later. There's an issue with callers with different area codes and how they get routed and who's triaged to do the mobile crisis response. So there's still a lot of work that needs to be done there. And then scheduling outpatient follow-up appointments in a manner that's synonymous with the warm handoff for ongoing care. That sounds great. As most of you probably know, there's a behavioral health workforce shortage. Access to outpatient and therapy, psychiatry, all of those things are very challenging right now. So really looking at a system that creates more access to these more long-term post-crisis follow-up services. And I will say, so all of this is rooted in, you can go to the CESSA website, you'll see a lot about 988, you'll see a lot about mobile crisis response and really the model that's being pushed out through the country. The 590 programming here in Illinois is funded through SAMHSA, as are some of the 988 initiatives. And one thing I tell people is you may sit down on a Sunday morning with your coffee and see a news report about how amazing mobile crisis response is in Georgia or New York City and all these different innovative models that are out there. And reality, each state is very different right now. And as I mentioned before, in the state of Illinois, each region is very different. So we are, I would say, as a state, behind most of the country in terms of being able to develop this system overall. So that's why there's a lot of misperception out there at times. Well, if I call 988, then I'll automatically get connected to an MCR team. Illinois is not at that point right now. So most of this is still in development. On that note, over the last, 7 months now since 988 was implemented, there's again been a lot of misperception about what 988 is and how it should be used. But 988 is a core component of the Illinois crisis system in terms of what's being developed and putting it at the center of the system. And so it's a new number. It's not a new hotline. And I think what's important for most people to know is that nothing has essentially changed. The hotline's always been there. We've made it easier for people to access that by reducing that 10-digit number to a 3-digit number. And the state of Illinois and across the country, they've been expanding the call centers. So really that's been the focus over the last year or two, is adding more call centers to be able to expand the capacity of 988 as it's been rolled out nationally as kind of a go-to. It's, as I said, the first step towards being able to really enhance the crisis system. What it isn't is it's not an automatic way to access mobile crisis response services. So as I mentioned, I hear all the time, we'll call 988 and get connected to you, right? And I'm like, well, no, there's no system for that right now that can outline how that's actually going to happen or how calls are going to be triaged. It certainly doesn't replace calling 911. It doesn't replace in the Medicaid system necessarily calling CARES. It doesn't replace other hotlines. All of those things are still available. And I always encourage people to still use 911 if they feel that there's any type of threat that would require some sort of intervention and response from law enforcement or first responders. The CARES line is still there for Medicaid system. In fact, there has been very little movement in terms of how do we make sure that people don't go through both CARES and 988 and get double dispatched on the mobile crisis response? So there's no system for that right now. And so if you have an individual who has Medicaid, you can still go through the CARES line, and that's the quickest way to get a mobile crisis response right now. It's also not a requirement to call the hotline prior to accessing other types of services or initiating hospitalization. I think there's kind of two thoughts on this. One is, initially when 988 was rolled out, there was a lot of pushback that, oh, don't call, you're going to be hospitalized immediately, versus kind of how the CARES line works in Illinois is, in order to hospitalize somebody, you need to go through CARES first and mobile crisis response. Neither one of those is true about 988. It's literally calling for help and support in the moment, which could lead to any number of follow-up services and supports being deployed. I also think it's not really communicated that this is really like a 2 to 4, I've even heard 5-year process across the state of Illinois. And so even though 590 funding went into effect about 18 months ago, we're still having basic challenges in hiring and providing just the 24/7 coverage, let alone some of the things that I'll talk about in terms of that are yet to be developed in the system. So always want people to keep in mind that this is a long process before we get to that overall vision in the state of Illinois. So when I refer to 590 programming, that's kind of second nature for me now, is to talk about crisis as 590. Really what that is that's the mobile crisis response teams. The Department of Mental Health put out funding where they took existing funding and new funding from the federal government and consolidated dollars to create this 590 program, which basically expands mobile crisis response, which was traditionally just community mental health centers doing it for youth specific to Medicaid, and expanding it to the entire population. So everybody has access to mobile crisis response in the future. Doesn't matter where you're located, doesn't matter what your age will be, it doesn't matter who your insurance is, whether you have insurance or not. It's kind of supposed to be similar or the equivalent to 911, but for mental health crisis situations. There are still EMS and law enforcement partnerships that a lot of us are working on to make sure that it's still a coordinated response. It's not a one or the other type situation, because if you're familiar with behavioral health crisis, it's never that clear cut, and there's always a need to have access to both at any given time. The MCR teams are the new aspect of mobile crisis response under the 590 program is that is a team response. In other words, in addition to being staffed 24/7, 365 days out of the year, we have requirements to have 2 individuals as part of that initial response. That first staff by state standards could be either a mental health professional or a qualified mental health professional. And the QMHP is typically somebody with a master's degree in a behavioral health field, or potentially an LPHA, a licensed clinician, and paired with somebody with lived experience, which is based on that SAMHSA model. So oftentimes you'll hear that referred to as peers, or there's a new credential called a CRSS, Certified Recovery Support Specialist, that makes up the the crisis team as a whole. So the idea is that mobile crisis response would be available. We'd receive the referral. We'd make the determination that mobile crisis response is needed. Our team would be dispatched to go out into the community to meet that person wherever they're experiencing that crisis. And the goal is to, as much as possible, de-escalate, resolve the crisis situation, or triage what the next steps might be, whether that be hospitalization or assisting them in getting more follow-up services in the community. And part of that is coordinating a plan for safety and like I said, the follow-up care. The state, through the 590 program, has expanded the number of mobile crisis response teams. So traditionally, mobile crisis response in the Medicaid system, you had one mobile crisis response team in these very small regions, which were called LANs, are now called DSAs, or designated service areas. But there really is no designated system. We haven't seen a map from DMH yet that shows kind of the coverage of each of the organizations. I believe last I saw there were about 83 mobile crisis response organizations across the state of Illinois. And I know in our communities, there's multiple. And so there's a lot of overlap in terms of we may be responding, but there may be others who cover the same areas that we do, which leads to how we triage those calls and understanding like when they would be referred to Pillars Community Health versus when they'd be referred to somebody else. So that's been a struggle at this point, is just understanding what the coverage is across the state. So CESSA is something that's thrown around quite a bit, the Community Emergency Services and Support Act. Governor Pritzker signed that into law in August of 2021. There were some there's a lot of information. I strongly encourage you, if you're not familiar with it, to look at it, because as a mental health provider, we've never really had to look at legislation related to law enforcement or incorporate that into what we do, and vice versa. Law enforcement is really learning a lot about the 590 requirements and how that's incorporated as part of CESSA. So it's good that it's bringing two systems closer together. Basically, the findings that led to the CESSA legislation are essentially that there needs to be parity between emergency for a physical health crisis versus a mental health crisis. And so that's what this system does, is create first responders and a call center system that's essentially the equivalent for 911. The legislation was very ambitious in indicating that it would have to be implemented by January 1st, 2023. Obviously, that day has come and gone. And as I mentioned on the previous slide, the state's really looking at a 2 to 4 year period to roll out, to develop this and to be able to implement all of this, these goals statewide. There are 3 conditions in the legislation that have to be met. And this is really important because a lot of people are like, why can't we just connect MCR to 988 now? Why isn't there a process in place? It's all being developed after 988's gone live, after the call centers are being implemented. And so there's a statewide committee that Sunil will talk about a little bit later on, that's negotiating all the protocols, operationalizing these different processes, script adjustments for 911, 988, and other call centers, so that things are connected much more efficiently. And then from that, there's also regional advisory committees. There will not be, or it doesn't look like there will be, a uniform statewide system. There may be variances from region to region regarding what some of the criteria is, or who responds when, or how the responses take place, which would make sense when you talk about Chicago versus a rural region in other parts of the state that doesn't have as many responders. And then really it's about the availability of mobile mental and behavioral health services in each jurisdiction, which is, while the funding's been awarded, the system is not fully developed because in part due to the workforce shortage, not having enough staff to be able to really provide this 24/7. We also don't know the volumes. There's never been any type of analysis that I'm aware of that says this is the call volume, this is the number we expect to go to 988, this is the amount or the criteria that will go to a mobile crisis response provider. So it becomes really challenging to figure out a model to how to deliver these services without knowing what kind of calls or when or how we'll be getting them. So some of the state goals that are listed in CESSA are specific to mobile crisis response. And so MCR will be available through 911 and 988. That's a whole separate conversation with separate committees working on how 911 connects to 988 and vice versa. As I mentioned before, mobile crisis response is just diverting from hospitalization. That's the goal, and really getting people linked to more community-based services. Really looking at doing that triage in the moment and making referrals as appropriate, as well as looking at transportation to the least restrictive setting. And so that ties into that fourth goal that I mentioned, or that third goal the state has in their vision around having crisis receiving centers. As I mentioned, there's only emergency rooms for the most part at this point. And so transportation to the emergency room is typically done through first responders and law enforcement. There's not a lot of options for transportation to other locations in the moment of a crisis. Other goals is really having the mobile crisis response system and the PSAPs, which are those point of entry services, call centers, whether it be 988, 911, or other types of call centers to provide guidance for prioritizing those calls. Establishing the response times. All emergency services must provide response within a specific time frame. The protocols are being established right now for all responders, law enforcement, other first responders, EMS, fire, as well as mobile crisis response providers. And then really, there's a lot of training that's needed within the 911 system. And even though there are new call centers popping up for 988 across the state and across the country, they are also struggling to find and train staff. And so training is finding qualified people and being able to train them and being able to receive a call from somebody in crisis and de-escalate or triage that call is something that's of significant importance. Some things to just be aware of that this is where it gets tricky. As I mentioned, Pillars Community Health works with about 28 different communities. And so that means we have about 28 different law enforcement groups, at least, to be working with. And they all do things a little bit differently. And they all have little different interpretations of CESSA and what they can do and what their system is currently set up to do. So some of the things in the CESSA guidance are that law enforcement shall not be dispatched. They are, unless there's a criminal activity or there's a threat of physical injury to that person or somebody else. Or if MCR is not available, there's been a huge push over the last decade or so to have more and more police officers and other first responders around the state be crisis intervention trained or CIT training. And so there still should be in many departments across the state officers on duty who are CIT trained if MCR is not available, or if the caller requests to have law enforcement respond. Regardless, law enforcement could decide to show up and be part of that response, and that they're technically not supposed to be used for transportation unless there's no alternative available. But at this time, there's really few alternatives. So overall, we're looking at a continuum within the state that really looks at the traditional law enforcement only, all the way to mobile crisis team and community-based, community involvement types of response. And there's a whole lot in between. And I think the real potential success of the system is the in-between. And there's a lot to still be worked out in terms of these coordinated responses that may require both, and who reacts when people are dispatched, which group is dispatched, how they work together, who takes the lead. There's a lot to still be worked out, but it's at least exciting to see a continuum being built in the state that looks at multiple ways that a crisis call can be responded to. Okay, I think I'm going to turn it over to you, Sydney.
Thank you, Greg. So part of the implementation of CESSA is the development of both state and regional committees. In these committees, in Region 8, we are currently working on identifying best practices. That includes the response times and when it's appropriate to have the police involved, or when it's appropriate for mobile crisis response teams to respond themselves. So the regional committees are charged with planning for and coordinating the responses between 911 and 988. Again, this is just the coordination between behavioral health teams and the police system. Changes in protocols, including dispatch times, decisions, are all part of what we're currently working on. These regional committees are led by EMS directors, so 911, the PSAPs, law enforcement, EMS providers, mental health providers. So there are quite a few in our area, as Greg mentioned. So we are all working together to develop this system to expand for the state. Currently, we're working with intermittent guidance from DMH. We are receiving some 988 referrals. They're calling them warm handoffs. So when we get a referral from 988, the 988 provider contacts us through our main number. Our peers, we call them engagement specialists on our team. So our engagement specialists are those individuals that accept those referrals from 988 and speak to the individuals in need. Right now, it's a little bit of, as the system is developing, it's a little bit unclear what we are, using as a guidance for assessing the needs of an individual. So as an organization, we have developed an acuity scale where we are identifying individuals that are calling us because maybe they need resources, maybe they just need to speak to someone over the phone. And then we're also sort of evaluating the need to respond through MCRT, which is just Mobile Crisis Response Team. That is when our engagement specialist will then initiate a response in person, along with one of our QMHPs, one of our master's clinicians. So we always want to have consent for a response in person. So that's really important to us as an organization. We want individuals to be part of the process and allow for us to respond to their location. It also depends on where they are. We do cover a large area, but we have seen some instances where we're getting referrals for individuals that are actually not in our area. So those times we want to clarify where they are, and if we know who the responder is in their area, we'll try to do a warm handoff to them as well. As needed, we may contact EMS. If an individual is either not in our area, but in a need, and we wouldn't necessarily have the luxury of time to be able to hand it off to another 988 provider, we do at times have to refer them to EMS as well. And then follow-ups with the Lifeline centers. So we try to sort of close a loop with any referrals from 988 with a follow-up. So some challenges, there are quite a few challenges. There's, like I said, not a real clear established criteria. When do we refer to 911? When is a 988 or MCRT, the appropriate response? Unclear expectations from SAS, MCRT referrals. So individuals covered under Medicaid traditionally would be referred to us through CARES. At times, we're finding that individuals are being referred through 988 to an MCRT provider, and then the families sort of having to go through multiple assessments to determine sort of the needs for that individual. So really some unclear expectations around that. Consent, involuntary petitions. I know that this has been sort of a hot topic in our regional committees. Part of the CESSA legislative is that we as 590 or MCRT providers should not petition anyone involuntarily. But of course, that creates some concerns around liability and really identifying the needs of an individual. So there's some challenges around involuntary petitions as well. Area codes, I'm not sure how we as a state were not aware, or as they started to develop 988, there were some maybe unclear expectations as to what the 988 centers or the Lifeline centers were going to be able to manage in terms of where an individual is. If you've ever had an area code that you no longer reside in, that's essentially what's happening, and the state is sort of recognizing that now. Individuals with area codes from other states that are now living in Illinois And so there's some issues in terms of who do we refer individuals that are calling the Lifeline centers. In our area, we have multiple providers, so there's no clear criteria on who receives what referrals or in what order. And then we've had instances in sort of the beginning stages of the referrals from 988 where they started to do what they were calling hot transfers, which is when an individual is in a high acute need, and they were forwarding them those to 590 providers versus EMS. So there was some initial challenges. It seems that is no longer the experience, at least in our organization. But I know that was something that we faced sort of in the very early stages. We're still working on developing the somewhere to go. So we have someone to call. That's the 988 providers, someone to respond. We're in developing the 590 response providers, and then the somewhere to go is still sort of unclear. And transportation, again, as Greg mentioned, EMS is pretty much the only transportation available currently. So we're seeing that as a major challenge. And then, of course, staffing challenges, developing a staffing model. It's been really difficult. We have very little data, unsure, projected volume. So unsure how much we need to staff up. Hiring, I'm sure everyone has experienced this at to some degree. There is a low workforce currently in behavioral health. Of course, the concerns with the lack of CRSSs currently in the state of Illinois. And then competitive state initiatives. So we're competing with ourselves often in filling positions within our organization. And I'm sure we're competing with others in our area as well. Retention, there's a high demand. It's a high demand job. We're competing with positions that are completely remote, compensation, of course, and community mental health. And then the complex crisis systems, it's really difficult to be an on-call provider. There's multiple referral points. So you have to sort of know the system really well in order to feel confident in it. There's limited referrals at this time. So it's unclear, again, like how our staffing model should look. And then supervision management in a 24-hour, 7-day-a-week sort of program is really difficult. It's easier to find a supervisor that's available during the day. It's a lot more difficult to find one that's available in the evening and especially overnight and weekends. So as an organization, we are available 24/7, 365. Our team is composed of our mobile crisis response clinicians. We do have a team lead as well. These are master's level clinicians. Our engagement specialists are CRSS eligible. So our engagement specialists are our peers, those with lived experience. We do have some case managers on our team as well, mental health professionals that assist in the follow-ups after a crisis to really identify, is there any issues with the resources we provided, or is there any need for continual support for those individuals that we've had contact with. Referral sources currently are the CARES line, still our top referral, and that is the traditional SAS MCR system. We do get referrals from our community. So from our outpatient programs, we do have individuals that call our 708 pillars number. It's our traditional crisis line, and we do evaluate those for MCRT. So we evaluate individuals that call our main number. We evaluate whether they need a response in person as well. Currently, we have very limited or a low number, I should say, of 988 referrals, but we do expect that to expand at some point.
Thank you, Sydney. One thing I want to clarify too, there's so much information to provide. We are currently available, as I think most crisis responders across the state, 24/7, 365. We are not available to do the MCRT through the 590 for 24 hours a day, every day of the week, every day of the year. And that's because of that staffing shortage. There are most 590 providers, based on the information in the collaboratives and the different meetings we have, are in the same situation as us. So we're actually only able to offer the MCRT under 590 for limited hours during the day, because we only have those CRSS positions available two of those positions available. So obviously we can't cover 24/7 with 2 staff, and we've been trying to recruit for well over 18 months at this point in time to fill that position. So I wanted to clarify that we are still available if anybody calls Pillars Community Health through 708 Pillars or through the CARES line, or gets referred to us in any other way to do that, to do the mobile crisis response, or some level of crisis intervention if it's not out in the community. But I just wanted to be clear on that, because there's a statewide staffing shortage, and if you're familiar, this is the time of year that DHS does a lot of their funding opportunities announcements, or as well as renewals, and they have created additional initiatives that also require CRSS staff to be part of those initiatives. And so when Sydney mentioned we're competing with ourselves, it's because we have a CRSS available. Where do we slot them? In the crisis program and in one of the other initiatives? There's just not enough individuals who meet these requirements in the state just to staff the crisis system, let alone all the other positions that are available. So that's a huge concern as the system gets developed, and why MCR under 590 and through 988 is still so limited at this point in time. That being said, it is, as I mentioned, provider to provider and region to region. It might look a little bit different. There are certainly places, I want to say the Memorial in Springfield comes to mind as being fully staffed or up and running. There's a few others, I think, that are a little bit more successful in getting closer to that 24/7, but it is certainly an issue across the board. So that's a lot of information. It's the experience basically is that there's been a lot of challenges as we try to build this out. And some of that is, as Sydney mentioned, a lack of guidance. Some of it as we seem to be putting it out there as a state that it's available when it's not fully developed and not truly available everywhere. And then it's, like I said, the state of Illinois is behind other states at this point in time. And so when you see things nationally, you often think, oh, this is how the system's supposed to work. And since there's 590 funding and there's 988 and there's CESSA, this is the way it's supposed to work in Illinois. So that's hopefully was beneficial to hear a little bit more about the crisis system and somewhat of our experience, but certainly would love to hopefully be able to answer any questions or if you have any feedback or comments.
Thank you so much. If you guys have any questions, I think we could probably, there's a small enough group here that you can go ahead and speak up and ask a question, or if you feel better, put it in the chat box as well.
I'll ask a question. Great presentation, by the way, and it's really cool to see just the model that you have with an FQHC integrated with a community mental health center and also having the domestic violence and sexual assault services. I don't know that I've quite seen that before, those three, the combination of those three things. So that's a really cool model. I guess one of my questions would be, does your FQHC have walk-in services or immediate care services, and what level of crisis assessment do you get out of that, or how often do you have people coming in crisis just through your kind of primary care or immediate care services?
Yeah, good question. It's certainly everything comes through our quote unquote CMHC crisis team. So if somebody walks into one of our health centers and expresses that they're identified as being in a behavioral health crisis, the referral would be made immediately to our crisis team. Where we utilize our health center is more in the follow-up if appropriate. So our psychiatry is based out of our health center. So if one of the follow-up services is connection to psychiatry and med management specifically, that could potentially go through our health center. We offer brief intervention for behavioral health as well. So if somebody has a very short-term need, it could potentially go through our health center or could go through our crisis team or our community support programming, or there's a variety of different services that are available. So everything still funnels through our mobile crisis response team, so to speak. And just again, want to be clear, that doesn't mean everybody gets a mobile crisis response. We do crisis intervention and de-escalation over the phone. It all depends on how the individual presents. But if somebody walks in anywhere in our organization, ultimately that referral, if they're in crisis, is made to our crisis team.
Thank you.
Sure.
Any other questions? Comments? I know we will have the slides that I'll make available once after the presentation here, and then we'll also have the link if you want to share it to anybody within your within your board. Please do so. And I think that's it. I don't think any other questions. Anybody else? Any last minute? We really appreciate you guys taking the time to be here today. Oh, I'm sorry, Ron. Go ahead.
There, I got out of mute. What do you see addressing the workforce shortage? And I meet with Dave Albert a couple of times a month. I'm on the Illinois Mental Health Planning and Advisory Council and the State Associations Committee. And I know, there's hubs that are happening downstate, as well as at University of Illinois Chicago at the Jane Addams School. What the main holdup seems to be finding bodies, and what's going to alleviate that?
Yeah, well, I wish we knew that. I wish we had that. That would be the big question. I think so. There's been a lot of attention on this over the last couple of years, right? And the state has passed legislation. They've dedicated dollars to, as you mentioned, these hubs, and really attracting people to the profession, providing access to whatever credential they're interested in, whether it be, a mental health professional or a licensed professional or the CRSS. There's a great program through the College of DuPage for individuals who are interested in the CRSS designation to get that sort of certificate there and provide an internship. So there's a lot of great things happening that will hopefully help in the future. The concern is the immediate. As the state rolls out some of these initiatives, those other things aren't the answer to the immediate. And I'm going to try not to get too much into personal opinion versus, I think one of the things I'll give an example. Last week, I sat in on a technical assistance call with DHS, where they're rolling out a new living room model across the state, which requires 24/7 coverage, or living rooms to be open 24/7, which is fantastic. That's the crisis center response or crisis receiving center here. One of the requirements is that they also include a CRSS 24/7, at least one on staff every shift, 365 days out of the year. In theory, that sounds fantastic. But what they've done is they've actually kind of further crippled the system, as opposed to how do we leverage the resources that we have? A thought process would be, how do you leverage the crisis system so that they're also tied into the living room model? So it's not just this whole community-based system and this whole living room system that are staffed completely separately. So I think the hope is that there will be some consideration as we look at these new initiatives, or as we roll things out within the system, to not just acknowledge that there's a workforce issue, but also look at how we better leverage the existing resources until the workforce does expand, hopefully in the very near future. But some of the things that are happening are things that'll expand the workforce years from now, as opposed to next week, when we need to hire people to work 11 p.m. to 7 a.m. on a Friday night in the crisis system. So I think, to me, that's the biggest holdup. Is I have many situations at Village Community Health where I've got an outstanding candidate, and I could plug them into one of 4 different positions and kind of have to choose, or let that person, in terms of where their interest is. And sometimes that means pulling a licensed clinician in one place and not being able to use them elsewhere, having a CRSS who's working in a program where it's established and very beneficial, and there's already an established need, versus putting them in the crisis team. And so it just becomes really challenging when you're kind of competing with yourself with the candidates that come through. And that's one thing Sydney mentioned too, is the supervisory pieces. Those supervisors have to be licensed clinicians, which are really hard to attract right now. Many new grads and licensed clinicians are opting for higher paying jobs, which makes perfect sense, with private practices or group practices or hospital systems. So that's also a challenge now too, is not as many people are choosing to work in a crisis system or in a community mental health system. So I wish I had the solution.
Yeah. I've tried to encourage them to waive licensing fees on those people who might want to return back to the field, who have left, you know, to pay people to go through the 40-hour training that you need before you can get your license renewed. You know, so that they get a stipend if they go through a week's worth of training, and then be able to take the test without a fee. You know, and you know, they have sponsorships where mental health centers can sponsor someone who, you know, maybe they've left the field because they got burned out at a managed care organization or something, but now it's 10 years later and their kids are in school or whatever, and maybe they want to come back. If they have the right supports, then you can get them up and running within, you know, 40 hours of training, you know, a week's worth of training or something like that. But I haven't heard that there's been a lot of bending on professional license and regulations. We have a lot of people who come in, immigrated from other countries, who have certificates from other countries, and what can we waive regarding that? There's a lot of veterans who may be providing those services under their position in the military service. However, they don't meet our state requirements. So I'm trying to get them to be creative, but I haven't seen too much develop out of those suggestions.
Yeah, there's things that are talked about or in the works. I know for people who've been out or let their license lapse, there's opportunities. We've triaged our wages over the last year or two and really had a significant increase, probably more so than most community mental health providers have, because it's a challenging thing to do within that system. We offer incentives to our staff. We offer free CEUs, free training, free prep for your exam, for your licensing exams. We're trying to do everything we can as well internally to make sure people are really obtaining the highest level of credential that they potentially can through the career path or whichever professional approach they've taken. So there's a lot of moving parts to it. And I think it will slowly start to get better. It's just how do we meet the immediate needs is very challenging.
Well, I know, and to try and find people whose licenses have lapsed, the database at the state of Illinois level is dismal.
Yes.
I looked up my daughter, who teaches at Jane Addams School of Social Work and has a current license. And she was there, and you know, her license was fine, and right below it was my mother's license, and her license as a nurse was inactive. My mom passed away in 1978. So she's still listed as an inactive license with the state of Illinois. And so to try and do a search on who's inactive really ends up with a lot of dead ends.
Yeah, yeah.
Any other questions? I want to thank both of you, Sydney and Greg, for putting this together and presenting. It certainly has been a very informative presentation. And you know, once again, you know, we'll look forward to the recording and the PowerPoint, and you may get some follow-up from people who weren't able to attend who might have a question or two.
That'd be great. I know, Jody, you have our email addresses as you do, Ron. So if there's anything that comes after the fact, please reach out to either Sydney or myself. But thank you for the opportunity to present today.
Thank you so much.
Thank you.
Bye, everyone. Have a great afternoon.
Bye.